This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on neck surgery. So there's three basic types of neck surgery: fusions, artificial disc replacements, and foraminotomies. We'll discuss all three. What are the reasons to do them? When do they work? When do they not work? And which one's best for each individual type of person? So first of all, the reasons for surgery. There's three basic reasons why we operate on necks. One is neck pain. Number two is nerve pain or weakness into the arms. And number three is spinal cord compression, which usually results in a loss of balance or jumpiness in the arms or legs, hyperreflexia. So the first reason to operate on necks, neck pain, is really the worst reason to operate on necks, because the fundamental problem is we don't always know what's causing the neck pain. Is it a disc, facet joints, nerve pressure, spinal cord compression? Is it muscle pain? Is somebody holding stress and tension in their neck and in their muscles? There's a lot of reasons for neck pain. The first key to success in spine surgery is typically, do we know what's causing the pain? And we never know 100%. It's always some degree of a guessing game, but it's also an odds game. Well, if the chances are 95% we know what's causing the pain, we can usually help people. The problem with neck pain is there's so many potential sources of pain that a lot of times we don't know which one's causing the pain, or at least the odds that we know what's causing the pain are just not very good. Sometimes it's only 50-50. So neck pain, occasionally we will operate on people for neck pain, but that's generally only if we really think we know what's actually causing the pain, and that's generally based on a multitude of studies: MRI, X-ray, bone scan, so that some different tests that really point to the area of the pain. And the other part is, obviously, if somebody's just totally incapacitated due to the pain and they've tried everything else and they're suffering, sometimes it's worth the risks of doing the surgery in hopes of helping somebody. So neck pain is the first category that is the worst reason to operate on people's necks, but you still do it if you think it really has a good chance of helping somebody. The second reason is the nerve pain or weakness in the arm. So if you get a pinched nerve in your neck and it shoots down your arm, first of all, generally we can know which nerve is being involved, therefore where the problem is coming from. And that's what makes it different than neck pain. Neck pain, we don't always know what's causing the pain. Well, with nerve pain, if you have pain that shoots down your arm and goes to your thumb, that's where the C6 nerve goes, with very high reproducibility in human beings. Therefore, if we look at an MRI and see they have a pinched nerve at C5-6, which is where the sixth nerve comes out, that gives us a high probability we know what's causing the pain. Therefore, surgery has a much better chance of working. And the same thing with weakness. If you have weakness of certain muscle groups in your arm, that can tell us which nerve is being affected. Therefore, it can have a higher chance of the surgery working. And the other component of that is if somebody has nerve pain, it drives them crazy. We have people walk into our office with their arm on top of their head because that's the only position of comfort, and they're in agony, and that relaxes the nerve a little bit. Generally, if we do surgery, they're going to wake up and feel better, generally right away. And so nerve pain it comes back to really one of the best reasons to do spine surgery, because also other treatments don't typically help a whole lot with nerve pain. The narcotic medications, anti-inflammatories, are not very helpful for nerve pain. Physical therapy and acupuncture, chiropractor, it's always worth trying all these other things. But after 6 to 8 weeks, if someone's still in agony, surgery has been shown to be very effective in treating nerve pain and weakness. And then the third reason that we operate on necks is for spinal cord compression. And this is obviously the most serious reason. It typically happens the older you get. You're more likely to get degeneration and spinal stenosis and compression of the spinal cord. The first thing that a lot of people notice is a loss of balance. Now, there's a lot of things that can cause a loss of balance: aging, peripheral neuropathy, all sorts of issues. But if you start to lose your balance, and it's every day. It's not just a come and go intermittent type of thing. You have lost some of your balance and you never get it back. And generally it's a broad base gait. So you walk with your feet wide as your shoulders, where you have more balance, and you're unable to do the heel to toe tandem walk that police officers make you do on the side of the road. Not me, of course, but other people. That heel to toe walk is the best test to know if you have a spinal cord problem and a loss of balance. If you're unable to do that, it can be from spinal cord compression, and we call it myelopathy. So that's something always to look out for. The other thing you can get is hyperreflexia. You can get jumpiness in your legs or in your arms. When a doctor tests your reflexes, they can be hyperexcited and jumpy. You can also get clonus, twitching of your fingers. Another big one is a loss of fine motor control of your fingers. If you start to feel floppy and clumsy hands, especially where you can't do buttons, if you can't button your own shirt without looking at it and doing it blindly, you've lost that fine motor control. It can be due to spinal cord compression, which is a very good reason to have surgery. Because once again, nothing else takes the pressure off the spinal cord except surgery. Everything else, time, acupuncture, chiropractor, physical therapy, injections, nothing mechanically will take the pressure off the spinal cord. Therefore, if you have spinal cord compression, surgery is usually indicated if you have physical findings, and it's the most effective in preserving someone's function and potentially allowing it to recover. So the three basic surgeries. Number one is the fusion. Number two, artificial disc replacement. Number three is the foraminotomy. First, we'll start with the fusion. The fusion is the gold standard. It's been around for 30, 40, 50 years. It's still the most common surgery done all over the world. I was in Germany a couple of years ago where they've been doing artificial disc replacements for 15, 20 years. And even in Germany, fusions are done at a 10-to-1 ratio to artificial discs. 10 fusions for every one artificial disc, even though the artificial disc has been around a long time and everybody thought that it was going to take over the whole market and fusions were no longer going to be done. So even in the country where they started, fusions are still done 10-to-1 compared to artificial discs. Why? Because the fusion is the most reliable treatment for that person's problem today. The fusion does three things. Basically, going from the front, very minimally invasive approach. We don't cut any muscle going in from the front. We go in between your throat and your sternocleidomastoid muscle. So it's pretty atraumatic. Then we basically put a metal pin into the bone and above and below the disc we're going to fuse. You know, fusion means get the two bones to fuse together. You want the two bones to grow together. So we take the disc out, put some bone into the disc space, stop the motion with a plate and screws. Bone grows across the disc space. The two bones fuse together. So if we're fusing the C5-6 disc, we're going to fuse C5 to C6, those two bones. So the surgery, we basically put two metal pins into C5 and C6 into the two bones and distract the bones open. When the disc degenerates, it collapses down. That collapsing down is bad. You lose your normal lordosis, the normal curvature to your spine. Your head starts to fall forward. So we want to distract the disc back open to a more normal height. And then also we want to take the whole disc out, and by distracting the bones open, it allows us to get into the disc and take all the disc out and take all the pressure off the nerve and off the spinal cord much more safely, because we've indirectly created more room by distracting the bones open with these metal pins. So we take the disc out, we use a microscope to go right back into the back of the disc space, take all the disc out. If there's any bone spurs, we're able to drill them down and to remove them, to take the pressure off the neural elements. And then the third part of the surgery is to put the spacer in. And we use either plastic or metal or bone, and we put a spacer into the disc space to keep the space distracted open. So the fusion works for three reasons. Number one is it distracts the disc space open to indirectly create more room for the nerves. Number two is we directly remove the bone spurs and the disc herniation and all the pressure on the nerves and the spinal cord. And number three is by putting the fusion device in and a metal plate on the front, typically with 2 screws up, 2 screws down, but there's a lot of different devices we can use. By stopping the motion, it stops any residual irritability of the nerve, and it stops the problem from coming back. See, bone spurs form due to motion through an arthritic joint, just like how your knuckles get bigger as you get older. Well, that's arthritis and degeneration through this joint that's moving every time you use your hand. That's why the bone spurs grow. Well, if you fuse a joint, you stop the motion that stops the bone spurs from forming. So if we do a fusion, we take all the bone spurs out, take all the disc out, take the pressure off the nerves, and then we fuse it, it stops the motion, the bone spurs won't come back. And that's why a fusion is so successful, because it does all three things: distraction, direct decompression of the nerves, and stopping the motion. And that's why it's been around forever. It's the gold standard. It's an excellent surgery. We've done fusions in professional athletes. We've done about 40. We reported on 25 of them just a year ago, and we found that 80% after a neck fusion were able to return to their professional sport. And this is all sports. We've done them in every sport you can imagine. Pro football is the most common sport, but we've done them in every sport: basketball, hockey, baseball, soccer. And the average return, 80% were able to return to their sport. The average return to their sport after the surgery was 9.5 months. It tends to be a little bit less these days. That early in the study, we were more conservative, waited till usually a year out from the surgery. Nowadays, we've let people go back as early as 5.5 and 6 months after a fusion. We let people go back once they're asymptomatic, all their symptoms have resolved, they've got good motion of the neck, they've completed the rehab program, all their muscles are strong enough to protect their neck, and if we see evidence of solid bone growth and a fusion on the x-rays and CT scan studies. The downside to the fusion is we're stopping the motion at that level. Now, most people think, well, I'm going to lose some motion on my neck. That's actually not very true. Yes, by definition, you lose motion from that segment when we fuse. But if you only fuse one level, most people don't notice a loss of range of motion. You may lose 3 to 5, maybe about 5% of the motion of your neck. Most people don't really notice that. 50% of all your motion occurs from the top two segments, and we almost never fuse those. And so it's usually a loss of motion is not the main issue for patients, especially from a one-level fusion. Now, the more levels you fuse, 2 levels, 3 levels, you're going to lose more motion, and then you will start to notice it. But the biggest problem with the fusion is because we've stopped the motion at that level, it transfers biomechanical stress to the other levels. So the disc above and below now have to move more and see more biomechanical stress. Well, that can accelerate the normal wear and tear that's already occurring at those levels. So we're getting wear and tear at all these levels in our neck all the time. But if you fuse one level, it can put more stress on the other ones and accelerate that process where you can develop a disc herniation or bone spurs or degeneration at one of the other levels. The incidence of that happening is around 20 to 30%. It's a little bit counterintuitive. We think that it's around 30% after a single level fusion. But what's counterintuitive, if you fuse 2 or 3 levels, that number drops down to around 20%. Well, that's weird because you think if you fuse more levels, you stop more motion, it should put more stress on the other discs, and that the incidence of developing other problems should go up the more levels you fuse. But what this one study, a famous study, showed the chance of developing problems at the other levels actually went down when you fused more levels. Well, that's counterintuitive. Why is that? The reason most likely is because the 3 discs in the middle, C4-5, C5-6, and C6-7, are the most likely to degenerate due to just the natural history of disc degenerating and humans wearing out. Those discs see the most stress of the weight of your head. And so if you fuse all 3 of those at the first surgery, you're less likely to develop other problems at other levels because you've taken care of the 3 that most likely get the problems in the first place. Whereas if you only fuse C5-6 right in the middle, you're more likely to have a problem at C4-5 or C6-7 above or below because those discs may have degenerated anyway, or at least they're more predisposed to degenerate in normal humans. So it's a little confusing, but that's basically why we come up with 20 to 30%, and it's within that range. But we do know what happens, and it biomechanically makes sense. We've seen it in the lab. So there's always a downside to every surgery. The downside to a fusion is it can put more stress on the other levels, and you may have to have a surgery on one of the other levels. So one of the great alternatives, which has been around for 15 years, more in Europe for even up to 20 years, but in America for at least 10, is the artificial disc replacement. And the artificial disc is the same surgery as the fusion. We go in from the front, very minimally invasive, very little disruption of the muscles. We do move your throat to the side for both surgeries. And obviously, I'll say my disclaimer right now, there are risks from all these surgeries. Risk of nerve injury, paralysis, stroke, heart attack, death. Overall, the risk of something very serious is around 1% in the literature. And most of those are temporary, but there's always a risk with everything. You need to really consult with your surgeon to know What are the risks in your case specifically? But anyway, the artificial disc replacement, very similar to the fusion. Go in, move your throat to the side. You can always get swallowing issues from the fusion or the artificial disc because we have to move your throat to the side to get down there. The more levels we operate on, the more likely you are to have that. A one-level surgery, it's pretty rare people get swallowing issues. So we move the throat to the side. We put those 2 metal pins in to distract the bones open, just like the fusion. We use the microscope to go in the back, drill out the bone spurs, and remove any disc herniations at the same time. The difference is with the artificial disc, instead of putting the bone and the metal plate on, we put a prosthesis in. And the prosthesis is an artificial disc replacement. And it typically has metal on one side, metal on the other side that stick into the bone, and then a piece of plastic in the middle, but it could be metal in the middle as well. And what happens is it allows motion in between the 2 vertebrae. So it does not stop the motion. And obviously the biggest benefit of that is it can put less stress on the adjacent discs. On the disc above and below can see less biomechanical stress and therefore may not accelerate the degeneration of those other levels. And that hasn't really been proven yet. It's a couple studies have come out with some promising results. We have proven that in the lab. We know that biomechanical testing shows less stress on the disc above and below after an artificial disc compared to a fusion. So we can extrapolate and say, okay, well, that should lead to less wear and tear and less risk for surgery at the other levels. But we don't exactly know that yet because remember what I said earlier is the natural history. A lot of these discs will degenerate anyway. But at least the artificial disc is promising, less stress on the other discs, and it preserves motion at that level. So you do preserve that functional range of motion, especially if you're going to do an artificial disc at 2 or 3 levels. That can be a definite benefit over a fusion and not decreasing the motion for the patient from a functional perspective. So the artificial disc is great, especially if somebody has a fresh disc herniation. So what that means is that biomechanically, the segment is pretty normal. The person was doing well, living a normal life, normal disc, working well, and they just got a big blowout, like a tire blowout. The disc herniated, it blew out, it went back, it hit the nerve, maybe hit the spinal cord. And we'll go in there and do our surgery, take out the disc herniation, the new problem. Well, that biomechanically, that segment was normal. We don't necessarily need to fuse it and stop all the motion. That segment was normal and doing okay till this blowout. So we can replace it with an artificial disc that can preserve the motion and just treat the patient's immediate problem. And that's when artificial discs work great in my experience is fresh herniations, acute problem, healthy person. It's an excellent surgery. The downside of the artificial disc is, well, we're preserving motion. So there's always a chance that if there were bone spurs or any residual stenosis way out on the side, you can still get some nerve irritability because you've preserved the motion. Whereas the fusion stops the motion, which is more likely to treat that nerve by not irritating anymore. So it's a trade-off. The fusion stops the motion, but it puts more stress on the other levels. The artificial disc preserves the motion, but you could have residual nerve irritability. Studies have been very promising, and on our experience has been very promising that we have not had more residual nerve irritability after an artificial disc than after a fusion because we directly decompress it. Under the microscope, we take everything out that's putting pressure on the nerve. But long term, 5, 10, 20, 30 years, will bone spurs form at that level because of the preservation of motion, which can irritate the nerve? Yes, that does happen. The question is to what degree. If it's only 2 to 5% of people, big deal. If it turns out to be 50% of people, well, we're going to have to change how we do things. And the other component of the artificial disc replacement is you have a facet joint in the back. You have 2 facet joints, one on each side in the back. So with the fusion, we treat the disc, we fuse the disc, and that stops the motion on the 2 facet joints in the back, stops any future problems from those or current pain or bone spurs off the facet joints. The artificial disc, we always want to look at the facet joints because if somebody has significant degeneration and bone spurs of the facet joints, we don't want to do an artificial disc replacement because they can have pain from those facet joints. And the bone spurs from the facet joints can impinge on the nerves and cause nerve pain. And that can happen. That's a reason not to do the artificial disc originally, but it can also happen down the road after an artificial disc replacement, 5, 10, 20, 30 years. Somebody may develop degeneration of the facet joints, which can be a source of pain and or a bone spur that pinches the nerve and causes nerve pain or weakness. So the last part about the artificial disc is, what's our backup plan? If an artificial disc doesn't work, what do we do to fix it? Fortunately, we can typically change the artificial disc out and do a fusion. That's much harder in the lumbar spine down in your lower back because you have your blood vessels, your aorta and your inferior vena cava can scar down to the front of your spine. So taking out a lumbar artificial disc and changing it to a fusion can be a really risky surgery because of those big blood vessels. Well, the nice thing about your neck is there's not a blood vessel that sits on the front of your spine that we have to worry about. Your carotid arteries are off to the side. What does sit on the front of your spine is your throat, is your esophagus. And so you can get scarring of that and you can develop swallowing issues by having to go back in a second time. But we've done that a lot, to change an artificial disc to a fusion. We've done a handful of those, but also to go back in on a fusion to fuse the next level or an adjacent level. We go back in, quite a bit, 20 to 30% of the time. And usually that's a safe, reproducible way to do it. So the point is, if the artificial disc does wear out, you can get subsidence, you can get wearing out of the prosthesis. After 30, 40, 50 years, the thing may wear out. It may form bone spurs. You may develop facet joint pain. If anything happens, we can typically change it to a fusion with a very safe surgery. Just go back in the front, take the thing out, do the fusion. And that's always nice. As a surgeon, I always want to know, what's my backup plan? What's the risk of it? How serious is it? If we have a good backup plan, sometimes we can push the envelope and do artificial discs or do other procedures because at least we know what our backup plan is. The other thing I want to say about the fusion that I kind of skipped over is one of the downsides of the fusion is you can get a failed fusion. Sometimes the bone doesn't grow. If the bone doesn't grow and somebody has pain from that, it's usually not life-threatening. It's not risky, but our backup plan is to go in the back. And we put in screws in between those facet joints with a rod in the back and fuse the facet joints in the back, which is also a very good backup plan. Now, our last category is the foraminotomy. And this means actually going in the back. Just like we take out disc herniations in the lumbar spine from the back with a microscope, we can do the same thing in the neck. Foraminotomy means make a hole in the foramen. So what we do is we go in the back, very small incision, we use a microscope, and we basically remove part of the facet joint, the medial part or the midline part of the facet joint. It's been shown in biomechanical studies that you can remove about 50% of the facet joint and still preserve stability because you have another facet joint on the other side and you have a disc in the front that's doing a lot of the stabilizing. So it's been shown you can remove about 50% of the facet joint. In our experience and in our practice, we really don't try and remove that much of the facet joint. We typically work from the opposite side of the table and undercut the joint, and typically we'll remove about 30% of the joint. The bottom line is you still have to remove however much joint you need to remove to take the pressure off the nerve. The key to the surgery is take the pressure off the nerve. But so it's a less invasive surgery than the fusion or the artificial disc because we're not putting any implants in. It's kind of a keyhole surgery. We just make more room for the nerve, and that's it. Surgery takes 45 minutes to an hour, and people can go home the same day. And so it's very appealing, but the downside is we can't always open up the hole for the nerve, which is the foramen. We can't always open up the foramen completely. Well, by definition, we can't open it up 100% because we can't take out 100% of the facet joint. We generally open up the entry zone, make sure we see the nerve root pulsating so we know it's working properly and the spinal fluid is passing through it. And also we can take out disc herniations, but the disc herniation is in front of the nerve. So we have to move the nerve a bit to get to the disc herniation, which can injure the nerve and people can get weakness or pain after the surgery. And also a lot of times people have bone spurs with the disc herniation. So we call it a disc osteophyte complex. An old disc herniation gets a bone spur on it, and we can't really take that out from the back because the nerve is in the way and it would require too big of a surgery to take it out. But by taking the roof off and making more room in the back, the bone spur can stay there. That can still give enough room for the nerve to drift back into the empty space and treat the symptoms. So the foraminotomy is a great surgery because it's less invasive, no implants, faster recovery, faster surgery, but it can also be limited. In fact, one of the only studies looked at in professional athletes showed around a 45% reoperation rate with foraminotomies in professional athletes, which is a really high number. It has not been that high in our experience, but it does happen. And the reason why is because it's not a fusion. Like I said, a fusion treats that nerve better than anything. It jacks the hole open, stops the motion, directly takes the pressure off the nerve. But there's a price to pay. It's a longer recovery, puts more stress on the other levels. The foraminotomy is nice, less invasive, faster, but it's limited in how much it can treat the nerve. And so one of the keys is all three of the surgeries are excellent options. And you really want to go to a surgeon who does all three. Most, surgeons who do a lot of spine surgery know how to do all three surgeries. And you want the surgery that's best for you, because everybody's problem is different. One of the great things about America is we have so many choices in spine surgery and implants and what can be done. But at the same time, you really want what's best for you as an individual, because every case is different. And there's plus and minuses to all three of these. The good news is all three of them have been shown to have very good results. If you have a pinched nerve and pain going down your arm, all three surgeries have shown an 80 to 90 to 95% success rate in significantly helping people. Typically in our practice, people's pain averages around a 6 or 7 out of 10 before the surgery, and it averages around a 2 out of 10 after the surgery, so which is a great reduction in pain. But also note a 2 out of 10 on average. Some people are to 0, some people are to 4. Some people still have pain and issues because they may have wear and tear at other levels. They may still have some residual irritability of that nerve. Surgery is amazing. What we're able to do, put somebody to sleep, go in, operate on their neck. They wake up, they feel better. It's really miraculous. At the same time, it's also limited. It's not always just a perfect fix. Sometimes we just help people significantly, and then it's their job to change their lifestyle and change what they're doing, change their daily habits to prevent the problems from coming back. Don't sit at a desk for 12 hours straight. Get up every hour and move and breathe and strengthen your muscles and exercise and live a healthy lifestyle. You got to help us out somewhat. So we do the surgery typically to take the pressure off the nerves and relieve the immediate pain or pressure off the spinal cord. And then the whole rehab program comes in after that. And recovery after these surgeries varies a bit. Generally, a fusion takes the longest. And I'll tell you our return to playing professional athletes, because that generally applies to most people. Most people are not 25 years old and in great shape like a pro athlete, but also they don't have to go back to a pro sport. They just go back to their life and a regular desk job. So you can extrapolate that the return to all function and everything is pretty similar. Our return in professional athletes after a neck fusion is typically between 7 and 9 months. The return after an artificial disc replacement is between 4 to 6 months, and the return after a foraminotomy is around 3 to 4 months. And we've had people go back sooner than all those ranges. We've also had people take longer. But those are generally the averages. Starting physical therapy, we generally start physical therapy 4 weeks after the foraminotomy, 6 weeks after the artificial disc replacement, and around 8 weeks after the fusion. And so, as you do the bigger surgery, it takes a little bit longer to recover. So that concludes our podcast for today. In review, we discussed a fusion, an artificial disc replacement, and a foraminotomy. All good surgeries, all have a good chance of helping people. They all have risks. If we can be of any help anytime, check our webpage, watkinsspine.com, or come see us in the office. Best of luck to you.